Get started. So I want to welcome everyone to the Substance Use Response Group's Prevention Subcommittee meeting, May 7th, 2025 at 3 p.m. We will go ahead and start with our call to order. So Dr. Hopkinson, are you able to help with establishing a roll call for quorum?
I am. As a note, all members serving in the Nevada State Legislature through the 2025 session are removed from quorum requirements for the duration of the session. And so we will now do roll call. Oh, sorry. Jessica Johnson.
Present.
Thank you. Eric Schoen.
Present.
Thank you. Angela Nichols.
Present.
Thank you. Debbie Nadler. I don't believe we expected Debbie, so thank you. And then Senator Donate, who I don't believe is on the call, but let's confirm. All right, so with 3 out of 5 members, we do have quorum.
Excellent. Thank you very much. Let's move to agenda item number 2, which is our period of public comment. I'm going to turn it over to Kim to walk us through the details on public comment. Thank you.
Thank you. So public comment will be received via this Zoom meeting by raising your hand or unmuting yourself when asked for public comment. Public comment should be limited to 3 minutes per person. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda item upon which action may be taken. If you are dialing in from a telephone, please dial 253-205-0468. When prompted, enter the meeting ID 825-0031-7472. You'll then press *6 so that we can prompt you to unmute. One additional note is that members of the public are requested to refrain from commenting outside the designated public comment periods unless specifically called upon by the chair. So we will have 2 periods of public comment. One is at the front end of the meeting and one will be later in the meeting. Okay, so we'll now open it for public comment.
Wonderful. Thank you. Do we have anyone for public comment today? All right. Seeing and hearing none. Going to go ahead and close the period of public comment and move on to agenda item number 3, which is to review and approve the March 5th, 2025 Prevention Subcommittee meeting minutes. I'll let committee members have a moment here for review, and then I would entertain a motion for review and approval of the minutes.
Madam Chair, I wasn't present in March, so I think I should abstain. But I think you and Angela are enough votes to pass this.
I second the motion if that was the
No,
Angela Nichols.
I'm not sure I should make the motion, Angela, because I wasn't
Oh, I'm
there.
sorry. I misheard
Maybe
that.
the DAG can weigh in.
So there actually is no hard fast rule that if you miss a meeting that you can't approve the minutes.
Got it.
So it
Okay.
really, yeah.
Well, then I'll move to approve the minutes as presented.
Thank
and I'll
you.
second the motion.
Thank you, Vice Chair Schoen and Member Nichols. I hear a motion and a second. All those in favor say aye.
Aye.
Aye. Any opposition and any abstentions? I think that's all the committee members today. So minutes are approved for March 5th. We'll go ahead and move on to agenda item number 4. We have some presenters joining us today. Thanks. Kim, do you mind flipping the slide when you have a chance, please? For agenda item number 4, we have Dr. Kelly Morgan and Josh Luftig joining us to talk about low barrier emergency department based naloxone distribution. I'm very excited for this presentation today. Dr. Morgan and Josh, I think you may have slides to share, so, or perhaps just speaking off the cuff. So
Yeah,
I'll go ahead and open for your presentation today.
great. Do you want, do I have the ability to share my screen?
You should. If you have any
Okay,
issues, let me know and I can give you permission, but it should be available.
great. Okay, let me see if I can get that happening. Mm, let's see if this. Oh, there we go. Okay. Uh,
I can see a screen, Josh, but it looks very zoomed in.
yeah, we're gonna be fixing that. Okay, let's
Okay.
see if we can. Okay, let's see if this is working. Is that looking a little
Yeah, you got
more
it.
correct?
Yes.
Okay,
Thank
okay.
you. Floor is yours.
So great. Thank you so much for having us today. And we're going to be talking about emergency department, the bridge program, and specifically naloxone distribution out of the emergency department. And I'm Josh Luftig. I'm a PA. I work in the emergency department in Oakland, California. But I'm also, the reason I'm here is I do national work around addiction care that is delivered from the emergency department and including harm reduction out of the emergency department and the naloxone distribution. It's my great honor to be joined by Kelly Morgan, who's a physician right in Nevada. And I'm going to actually have her, I'll do the disclosures, which is I have no conflicts of interest. A lot of our work is funded by the Opioid Response Network. And we're going to start off with Kelly's going to take us, kick things off here and tell us about her experience in Nevada in the ER.
Great. So thanks so much, Josh. The reason that we were asked to kind of come and present to this committee in particular is to talk about some of the challenges that we have seen around emergency department distribution of naloxone. I have been fortunate enough to work with Josh and his team from Bridge on a number of different initiatives with the Bridge program through the emergency departments. And that does encompass harm reduction techniques through the ER, such as naloxone distribution. We're currently working on the integration of peer navigators within the emergency departments, and next quarter we're actually looking to launch buprenorphine as part of the 911 system. So this has kind of been a whole longitudinal project, if you will, over the last couple of years, trying to get the care to the folks that need it. And myself and Dr. Dave Hart have probably been the two biggest emergency department local champions, if you will, at least in Southern Nevada, on trying to move the needle on this particular topic. And I think I was asked to sort of talk a little bit about, what some of those challenges have been. And I think that part of it has been around stigma and hospitals, not wanting to do things that attract substance use patients to their emergency departments. And they feel that, and I'm going to put words in people's mouths, but I think that there is a sentiment that if we put harm reduction supplies and make that available within the emergency departments, we will attract more patients that have substance use disorders. And when I presented this to a lot of the healthcare executives back in February, I said, guess what? They're already in your emergency departments. So this is kind of an unfounded fear. And what we really should be doing is playing a much more prominent role in aiding people in harm reduction. And so I can tell you from experience of trying to get what I deemed as the Halloween style kind of candy jar of naloxone just sitting in my hallways that anybody could take one when they needed it. That was met with quite a bit of resistance from a lot of the hospitals, and particularly some of the pharmacy departments, about who actually was supposed to oversee those programs. Hospitals not having a dispensing pharmacy license, and so therefore they felt like they couldn't do that. Those boxes of naloxone not having a patient name on it and identifiers and things like that. And so I think that that was one of the kind of some of the barriers that we have kind of seen. You know, you're technically giving a medication, and so does a nurse need to do that? What does that need to look like? And I think that the more reasons they could come up with not to do something, it enabled them to not just go ahead and take the jump to put naloxone into the emergency departments, or to make it an easy access site for community distribution of naloxone. But what we do know from the emergency department is that patients who acutely overdose on opiates now are not leaving for the most part. There's a couple of sporadic programs. Mountain View has had one through Dave Hart. They are not leaving with naloxone in hand, and most patients that I see are not going to a pharmacy to fill a prescription, to deal with sometimes the stigma that comes with having to say, hey, I need naloxone. And being asked, why do you need it? Can you pay for it? Where is your ID? And some of the same challenges that we see around patients filling buprenorphine prescriptions, they're also getting around naloxone. And so kind of my experience has been, if we don't do it in the emergency department, in the hospital, and patients aren't leaving with it in hand, they're not going to get it at all, unless they are finding it at some other offsite. So I think that's kind of been my local perspective on what has happened. Just from my frontline experience, I know that we are doing this within our EMS system and say, hey, here, take a kit, take the resources. We want to make sure that people have naloxone, and somehow that has not trickled into the hospital systems. And I think that this is a significant area for improvement. So, Josh, you can go to the next slide. So kind of setting the stage, obviously we know that, you know, opiate related doses deaths continue to go up. There's been 30% overall increase. Last year was the first year that the national data went down, and it went down significantly, except in 5 states. And congratulations, Nevada was one of the 5 that went up, second only to Alaska. And so despite some of the efforts that we've been putting in, we're still not moving the needle as effectively as we would like in terms of our overdose deaths. So there were 42% increase, huge increases in fentanyl related overdoses, and we're seeing more and more encounters related to fentanyl, obviously in the emergency department. And those numbers came from the statewide plan. And then I've got a couple slides with a little bit more information. So obviously this is kind of the trend. These are things that we all know to be true, as you can see that the synthetic opioids, other than methadone, which is mostly fentanyl, has gone up at astronomical rates. And that reflects what we are seeing in the emergency department and nationally. So when we kind of look at some of the Nevada statewide statistics as well, and I will thank all of my friends at SNHD for putting together some of these. These were the crude death rates for opiate overdose. Here's some of your highest, your zip codes that are the highest rate of opiate overdose related deaths, 89101. So right downtown kind of being the highest area within Clark County. And those are numbers basically for a 10-month period from October of 23 to August of 24. And those were numbers pulled from the Clark County Opioid Task Force report that came out recently. One of the slides previous was just kind of a map of some of those similar numbers along the zip codes. So you can see that right there. And it's just a nice little heat map of where we're seeing these things pop up. And then I think there was one more. And when we look at kind of our substance use related dependence from the 2023 numbers, we're looking at how many patients are being seen in hospitals, and you're looking at 72,000 hospital encounters. What percentage of those patients have Medicaid? And we're looking at 52.6%, you know, and so I think that this shows us that the patients with substance use disorders are ending up in our emergency departments anyway. So it's a prime location to really encourage community distribution of naloxone. Okay. Josh, you're it, my friend. Talk to us about Bridge.
Okay. Thanks. Thank you, Kelly. I just got a little alert that my internet connection is unstable. So start waving your arms if you can't hear me. So Bridge impact to date. So we've just to kind of look broadly at what we've been doing is we were starting to identify more patients for substance use disorders. These are patients that are, as Kelly said, these are, Dr. Morgan mentioned, these are existing patients that are we're already seeing in the ER, but now we're actually identifying the underlying use disorder that's driving all the ER visits and starting to intervene. And part of the intervention is identifying the opioid use disorder specifically and prescribing MAT. So actually administering and prescribing buprenorphine. So these encounters, patients are actually initiating in treatment. And the other piece that we're really focused on today is the naloxone piece. So these patients are getting naloxone in hand. These are take home in hand naloxone. We're not relying on a prescription. um, Sorry, let me get that next slide. Of course, we know naloxone is an opioid antagonist. It blocks and reverses opioids for 30 to 60 minutes. It has no known adverse effects, no known allergic reactions, there's no potential for abuse. There's no street value. In fact, there's a negative street value in the sense that we're trying to get patients who really should have it on hand to have it, rather than having so we're actually pushing it on patients, much of the way you would give people bike helmets or fire extinguishers, as a public health intervention, and is not a controlled substance. Community distribution has been a thing since the 1990s in the United States. That's lay distribution in schools and on the street corners, out of syringe exchanges, et cetera. Like this has been a generally not a healthcare distribution thing. Just the lay public has been passing this medication out to people at risk since the 1990s. It comes in multiple formulations. The one we're focused on today is the intranasal spray, which was released within the last decade, and it's been a game changer because it's relatively inexpensive and it's very simple to administer. It's very complicated to give an injection, very simple to give a nasal spray. It reverses an overdose by displacing the opioid on the mu receptor in the brain, and it has higher affinity to that receptor, and it just pushes the opioid off and thereby restores breathing. The problem with the existing with having just relying on prescribing is that you have only 11% of patients are actually getting a prescription. 11% of patients who should have naloxone are even getting a prescription, and only 1.6% who are at risk for an overdose are having that prescription filled. So it's a failed intervention to just rely on prescribing. So more than 90%, more than 98% of patients are not actually receiving naloxone, which is life-saving for these patients. Why is the ED really important as a touch point for naloxone distribution? So we have nearly 50% of ED visits are substance use related. Anyone who spends a moment in an emergency department recognizes this immediately. There is a huge enriched population that is the natural population that accumulates in emergency departments that have the highest risk. The higher risk you are, the more severe your substance use disorder is, the more likely you are to be receiving your care in the emergency department, and likely only that being your only healthcare touch point. We offer all hours safe access, which is there's nowhere else that offers that. We also have acute psychiatric stabilization, same day treatment, meaning we are able to give buprenorphine and start people on treatment right there, which is something that most syringe exchanges and most other touch points for naloxone are unable to do. And we can also navigate people to ongoing care. We're really good at linking people to care. So we start the treatment and we get them into follow-up. EDs are well distributed geographically. So across Nevada, you have EDs, these safety nets that are emergency departments serve over 250,000 patients in rural Nevada. So we're not just supporting the urban areas, but this really becomes a center for supporting our rural populations. The other thing is there's this really high risk moment that happens after a non-fatal overdose. So when when an overdose is reversed in the community and that patient is brought into the ER, that patient carries a substantial risk, even though their life has been saved in that moment. They carry a substantial risk for having a repeat overdose. So they have a 5% risk of dying within a year, which is similar to having the risk that's associated with a heart attack. And they're most of that risk is compressed into that first 48 hours. So there's nowhere else that we can refer someone to take care of that risk, that elevated risk. We have to address it right in the emergency department. We have to have naloxone to hand right to them so that they can be safe for that first 48 hours post-discharge. The entire bridge model includes low barrier treatment. So we're meaning that we administer and prescribe buprenorphine, the life-saving medication that is actually engages people in treatment and retains them in treatment and stabilizes their use disorder. We also have linkage to care and community. So we're making sure that they have follow-up appointments and a place to go right after the ER. And then we have the culture of harm reduction, which includes the naloxone distribution. Okay, we know that all these elements have really powerful impacts. The buprenorphine and the ED more than doubles retention and treatment. The navigators that are connecting people to outpatient care are nearly doubling the retention and treatment. And the naloxone that we distribute from the ER, an estimated 16% of recipients from the ER go on to reverse an overdose. So it's really an impactful population to be distributing to. So instead of a revolving door of frequent flyers with little or no intervention, each encounter is an opportunity to re-engage in treatment and immediately restart addiction treatment and provide naloxone. So where's the pain point in terms of actually what Dr. Morgan is describing, where we have this medication, we have this intervention, we have the people who want to give it to the recipients. The recipients want to receive it, and we can't get there. So what's going on? So Nevada has they have distribution via standing order is permitted, which is true in most states. So they have it in the statutes that you can distribute via standing order. And there is a mechanism for emergency departments to apply for naloxone. So the ERs can apply to the Nevada State Opioid Response Naloxone Distribution Project, but low barrier distribution is still not occurring. So why is that? One, there's a complex regulatory environment that has a chilling effect on ED and hospital participation. So there's so many rules. It is the most complicated place to get a medication to a patient through a hospital system, right? You've got a pharmacy, you've got the pharmacist with a zillion rules. You've got rules around storage, you've got rules around labeling of the naloxone. It makes it much more complicated than if you're distributing from a library, a syringe exchange, anywhere but a hospital that doesn't have all these rules. And without guidance and regulation and regulatory exemption, EDs are forced to follow these complicated protocols with minimal impact, meaning that we're not actually, even if you go through all those steps, you're going to give out like 1 or 2 kits a day at most. Like it's really hard it's a cumbersome system. What has changed recently is that the FDA has made naloxone over the counter since 2013. So now that standing order, which most of the legislation is written around the fact that it used to be a prescribed medication, now it's over the counter. So there's no standing order needed and there's no prescription needed. So that's going to loosen things up. So what's working well? Where can we look for an example where we've actually achieved low barrier distribution? And this is what I know because this is where I did the work, and I can attest to how we were able to overcome these barriers. So we reached out to our board of pharmacy and additionally Health and Human Services and our Department of Public Health. But mainly it really was the board of pharmacy. That's why it's bolded, is because they're the ones who need to exempt emergency departments from these regulations. And provided that the ED store public distribution naloxone separately from hospital formulary medications and follow specific policies in the form of a standard operating procedure. So that's the mechanism where you exclude this type of program from the hospital formulary medications. The exemption was posted on Health and Human Services naloxone distribution program website, and we offered template standard operating procedures to the hospitals as guidance. So they weren't left up to their own devices to try and formulate their entire standard operating protocol. So it just handed to them. They just wrote their name in, they wrote the hospital name and the date and signed it, and that was it. We also have started to do multiple methods of distribution. There's 2 main categories. One is direct in-hand distribution, where a provider or a nurse or a substance use navigator anyone who is at the hospital or a volunteer hands the kits to a patient. And that's what most people think of, but there's actually the other way is really effective, and we really moved into this space as well, which is automated distribution or passive distribution using a distribution stand, a vending machine, or a countertop basket. Now, out of all those three, really the distribution stand is the powerhouse. You see on the right that these little these newspaper stands, style distribution stands, they're not locked. They can be indoor and outdoor. They're virtually indestructible. We have them parked outside of our ED waiting room entrance. So the entrance to the ER just on the street in the shade. And then we have another one that's inside our waiting room, so that people can just access naloxone in the most low barrier way possible. There's a description that you can download from our website, which has a guide goes into depth about these distribution stands, all the different ways of distributing, all the FAQ. There's a lot of resources around how to establish these types of distribution processes. The training is no longer required. There used to be, because it was a prescribed medication. Now that it's over the counter, all over the counter medications have to have labeling that instructs the user directly. So you don't have training when you get any over-the-counter medications like ibuprofen or acetaminophen, Tylenol. You just look at the package and follow the instructions. Same thing with naloxone. They made it very easy. That being said, we do like to apply our own labels so that they have access to treatment, because these kits get passed around. We'd like to have a number to a helpline so that people can get access to treatment as well. And we put those labels on every kit. The impact has been tremendous. We went from basically 7 kits a month that we were distributing to over 500 kits a month by implementing these types of processes. Statewide, we now have over 300,000 kits that have been distributed for free over the life of the program. And before that, there were no kits that were being distributed for free. So it really does work. The way in Nevada, this is similar to California. One way to think about it is you have up on the top here is the providers of naloxone that are coming from funding sources. Often, they can be federal grants, they can be state grants. They go to the state of Nevada, and they're distributing naloxone to all these qualified entities on the bottom. And really, it's leveraging these existing structures and the manpower or person power at these different facilities, like at the ER that offers this 24/7 safe access and all these other resources on top of the naloxone. So the value add is incredible. All you have to do is have the state provide naloxone, and we will take care of all the distribution piece of it. Which regulations require exemption? So it's basically the regulatory domains include medication dispensing, labeling, maintenance, storage, packaging, and security. If you map all that to these regulations, these are the precise regulations that would be exempted. And there will be an addendum that provides the actual text of all those regulatory codes. So the recommendation is that we request state bodies, namely the Board of Pharmacy, to permit low barrier distribution from emergency departments, to permit EDs to adopt a naloxone specific standard operating procedure for public, or SOP, for public naloxone distribution via standing order. That actually just no longer via standing order. I'm deleting that in real time. Separate from and exempt from the regulatory framework surrounding hospital formula medications for use in patient care, and that distribution stands be established in front of and or inside ED emergency department waiting rooms. Now, those can either be provided by the hospital itself or in partnership with local harm reduction organizations, which can actually be a way to expedite this. So if you have a Department of Public Health program that says, we want to provide a distribution stand in your lobby, do you have any objections? Usually hospitals are like, sounds great. The state body wants to do this. We're just going to provide the footprint. And often that can be the entire conversation, and they're happy to provide that service. And that template documents be made available to healthcare systems. So templates such as standard operating procedure, log sheet, program decision and a program description can be provided on an agency website like the Board of Pharmacy or a third party website such as the Center for Addiction Application of Substance Use Technologies. So yeah, so and I actually have draft documents that will be provided as an addendum that you could use directly. You could just copy and paste those and have that be your SOP if you would like, or you can modify them if you see fit. Consider opioid settlement funds and other funding opportunities for naloxone and of course these other life-saving interventions. In the interest of time, I'm going to wrap up, and here is contact information for myself and Dr. Morgan.
Wonderful. Thank you so much for an excellent presentation contextualizing to Nevada and sharing the lessons learned with the Bridge program. I'll look to my colleagues on the SURG Prevention Subcommittee for any questions from the presentation. Eric or Angela?
Yeah, no questions per se. I just want to say thank you for such an excellent presentation. I too am a big believer in getting naloxone out to as many people as possible. And the graph that you had showing that the highest risk was those first 48 hours was particularly impactful, and I think really underscores the reason for why we want naloxone to be as readily available for those folks as possible.
Thank you for your comments, Eric. And I'm really grateful to the presentation today, Josh and Kelly. I had written down kind of some of the components that you had mentioned around stigma, the giving a medication, leaving naloxone in hand. I was wondering if, Josh, if you could talk a little bit about some of the multiple methods of distribution. I know you kind of brought that home at the end. How do you see those complementing each other, kind of in boots on the ground in the real world?
So like this, yeah, okay. It seems like it's really a belt and suspenders approach in the sense that if you really want to saturate with naloxone and make sure that everyone at risk and then everyone surrounding that person at risk, so their friends and family and community members who can intervene in a position to intervene, has access to naloxone, you kind of need both. And if you do direct in hand, the benefit of that is you can really engage around the topic and talk about. I mean, it's really powerful. Great rapport, great conversation between a provider or a nurse or a tech or anyone to just like have that direct connection where you're like, I really want you to have this. This is why it's important to carry it. And interestingly, for people who are not yet engaged in, say, treatment MAT with buprenorphine, when you start to have these conversations, they realize that the ED really is in their corner trying to have practical solutions for their health and safety. Then they start to get trust around that healthcare setting, and then will later come back and engage in treatment. It's a really powerful impact. So that's the two thumbs up for the in-hand distribution. As far as the automated passive distribution, the beauty of that is just you don't have to be a patient, so you can be a community member. It really expands the whole concept of what the hospital can do in the community. It makes it so that this can be a touch point for the entire community to access naloxone. And then people who aren't even engaged in healthcare at all are kind of going, wow, the ER is providing this. And then they may even get in the door. Maybe any 24/7, if they're coming and getting their naloxone from that vending machine or distribution stand, they can always at any point check in and say, I need help, and get started on buprenorphine right in that encounter. So yeah, and it just, I think the vending machines we're doing most of our volume through the distribution stands. Now, the other thing is there are vending machines, which are like the same as the snack machines. And those are neat. And actually, Nevada has pioneered a lot of that work around vending machines and done an amazing job. They're much more expensive. They have a bigger footprint. They tend to be more of in my experience, take more buy-in from the institution in terms of institutional support. ongoing costs. It's a lot to get them going. And the bang is not quite there. The little distribution stands are performers in terms of getting naloxone to the community, and we have a bunch of them. So we now have our county. We're going to put 70 of those distribution stands around the county, and we have we're going to have, you know, in our hospital system, you know, in my hospital, our hospital, we have 4 right now. We have 1 in dental, we have 2 in the ER, we have 1 in our addiction clinic, we have 1 in all of our general. We just have them on the floors. You can just put them anywhere. There's really almost nowhere you can't put them. The only place you shouldn't put them is like in direct sunlight in Nevada. That would be a bad idea. But anywhere else in the shade outdoors, they can freeze. Um, it's just amazing. So the Loxone is an incredibly stable molecule. And you know, in the middle of an opioid crisis, putting these around, if you know, it just gets around so many barriers. It also doesn't require any staff intervention. So we just have to fill it and then it runs itself. We don't have to remember to give it. We don't have to. So I'm a huge fan of, if you can't get to in hand initially, just partner with your local Department of Public Health or community syringe or community harm reduction org, and see if you can have them, you know, provide it, and you can help stock it, or even have them stock it. Like, just having the ER as a place where these are established is so impactful.
Can I add on that for just 2 seconds too? I think
Yeah.
that a lot of times, like, we see patients with substance use disorders and specifically opiate use disorders, and maybe they didn't come in that day for an acute overdose, a non-fatal overdose, but maybe they were there because they had a wound. Maybe they were there for some other reason. By having kind of the passive distribution methods and stuff that are available, maybe they would have fallen out of the direct in-hand distribution because they weren't there for an acute overdose, or somebody didn't think to ask them, or they lied about, you know, do you have a substance use disorder? Do you use drugs? I mean, people, there's a lot of ways, or a lot of reasons that people may not be forthcoming for that. And so if their visit isn't around their opiate use disorders, then the passive distribution also allows us to have that opportunity for somebody to leave the ER with naloxone in hand, even though that's not why they showed up in the first place. And so I think that was the other point I wanted to make.
Thank you both very much. If I know we have just a couple minutes left for questions, I think my other question, Josh, I was wondering if you could talk about the kind of acceptability and how this has been received. Has there been a difference between your urban and rural communities across California, and what the impact has been?
Yeah. So we have so it's been accepted in across the state. So we have 200 hospitals at this point who are doing it. So we're talking academic, community hospitals, rural hospitals, tiny hospitals in the middle of nowhere. And the rural hospital I'm most familiar with is in Placerville, and it really is the anchor for the entire county. So it's Diablo County. They're in the foothills, and they just so the hospital has become an anchor point. They have patients who are like, you know, their life was saved by the kit that came out from the ER that they had, the distribution stand. So and then as far as community acceptance, it's been, you know, these labels are really, if you see on the right, this is the label we have. I'm a real big proponent of labeling access to treatment with naloxone. Naloxone in itself is pretty widely accepted. It's not, there are some people who you know, who reject it as an idea. But once you put an access to treatment, it's very hard to, it's so compelling. You've got the reversal agent, you've got a connection to treatment. I think the one pushback you can get is if there's no linked to treatment that's paired with any form of harm reduction. If those are completely separate, then some people will object to that. But if you pair them, you kind of have a bulletproof program, and it is a true value add to have access to treatment in some form. How do I get treatment linked to the distribution? So I think that would be the only. But in terms of anyone sort of laying down in front of bulldozer and saying, no way should this happen. We haven't seen that. We've seen honestly the opposite. It's been just celebrated. We've had newspaper articles, uh, interviews, and I mean, people just get really excited about it because they feel like there's a lot of hopelessness around the opioid crisis, and when they see programs that are working, and they just tend to get really excited and very positive feedback.
Thank you both very much. I probably should have started with, I put in a draft recommendation around community access of naloxone for the prevention committee, and just really grateful that both of you were able to dedicate your time to be here today to share not only the lived experience of doing this work in EDs and some of the barriers that you've run into, Dr. Morgan, and then Josh, kind of some of these models that have worked elsewhere that we might be able to consider, and how barriers were addressed. So thank you both very much today for your presentation and information, and sharing your lived experience of not only program implementation, challenges and successes.
Great.
Thanks so much for having us.
Yeah.
Now, how do I?
Unshare? I don't know the answer to that.
I'll tell you what. Well, I'll log out, and thank you all, and bye-bye.
Thanks, Josh.
Thanks,
Appreciate it.
guys.
You're welcome.
Wonderful.
I will
Go ahead.
just check to make sure that folks can see my PowerPoint is back up. Is that correct?
Yes,
Thank
your
you.
PowerPoint is back up. Thank you so much. So really glad that we could start off with the presentation. I know both providers had to run back to work, so glad we could get that going. We're going to move to agenda item number 5, which is a review of the progress on our prior SURG prevention subcommittee recommendations. And for this, I'm going to turn it over to Laura and Kim to walk us through these pieces. The floor is yours.
Thanks, Jessica. So the first slide is just some process considerations about timing. So, for example, the budget process for any state agency is a long-range process. So if you're saying, making a recommendation and saying you want something in the budget this biennium, that's never going to work. You're almost always going to want to say next biennium, because by the time they get your recommendations, they will already have submitted to the governor's office what their budget is for the next coming biennium, because it has to go through many rounds of approval. So so there's just an example there that you can look at in detail. And then on bill draft requests, when you submit those, you want to have a specific person or an agency or other entity, like sometimes boards might have an allocation of bill draft requests that they can do. So if you're not putting it to a specific legislator or agency or board, it's not probably going to go very far. So you just kind of going forward. And it relates to some of the past recommendations, and we're working on doing some updates. So unless anybody has questions about that, we can go on to the next slide. Oh, yeah. So yeah, delay, kind of talked about that. Oh, also, we got information from state Medicaid about the spas. So when they have to ask national, the Centers for Medicaid and Medicare for a variance to how they spend dollars in Nevada under Medicaid, the timeline can be from 90 days to over 2 years. So those can take a very long time to process and then implement. And some of you may be familiar with that already, but we just wanted to make sure everybody understood the kind of timeframes that occur for those big major efforts that need national approval. Okay. We last year did provide updates on recommendations from the SURG in October. And we worked with the various divisions and bureaus under the Department of Health and Human Services to say, going forward, that we'll try to always have you update in October, because that's a better time frame for them. We understand that there can be things happening in between, and we can try to get answers to your questions in between. But when it's drilling down into the details of activities around those recommendations, it's better to do it in October, just because it's hard for us, like right now, because we're in the middle of a session, the departments are working on the legislative stuff. It's harder to get timely updates then. So, however, we are working on this. So we have a tracker, and I just want to say thank you to Brianne Van Dyne. I know she was here earlier, but it looks like she's signed out now. But she gave me quite a lot of activities that they're working on with their subgrantees. And so I want to share or ask him to share a spreadsheet with you that shows some of that. So this is a work in progress, and it's showing recommendations over the last few years, as and it's kind of the 2024 is at the top of each cell, so you can see in that first column. So that was your recommendation to increase the budget. And again, for this biennium, that's hard for them to do, because by the time they get it, their process has long since been forwarded onto the governor and to the legislature. So you would always want to say at least the next, so like for this year, because this is a legislative year and we're on a biennial framework, if you want them to do something with the budget, you would need to do that now and say next biennium. When you're on the off legislative year, likely they will already have started that process too. It's always, it's 2, almost 3 year difference between when you're recommending it and when they need it. So you got to look out to the future on budget stuff. Just to explain this spreadsheet, so the first column are the recommendations, and you can see there's stuff from 24, stuff from 23, 22. In this case, this first one, these are all from prevention, but in some other cases, there might be things from the other subcommittees that were related to that. And so I tried to group some of those together. Once we have this finalized and we have an opportunity to cross our T's and dot our I's and get the other, because this particular document contains all of the subcommittee recommendations. Once we get a chance to update all of them, then we'll make it available to the subcommittee so you can review it in more detail. But we just wanted to know that we are being responsive to your request to try to get updates on this. And in fact, these May 7th updates you'll see in the second column, Brianna did provide those to me yesterday. So these are very timely. And what this is different grants that go out under the Bureau of Behavioral Health, Wellness, and Prevention. And it may not be specifically doing what you requested, but it's related to that. It's saying we are spending money on these activities that the prevention subcommittee members have, wanted doing, but it's not necessarily a direct match. And then, as you know, we're in the middle of a legislative session. It's kind of winding down, but we're trying to put things into this spreadsheet that also relate to bills and what the statuses are. Kim, if you want to scroll down a little bit, we'll just kind of highlight some of the other things going on here.
Yeah, I'll just note, Laura, we are close on time, so we'll just want to scroll through. If you just want to let me know where you want me to pause.
So the ones in this green color are the ones that are from prevention, and it's the same kind of format. If you go down a little further, you'll see one that are in kind of a light gold color. Those are your harm reduction things. And again, the middle column is giving you updates that we've received either currently or in the past. And again, it includes, multiple years. Sometimes you have a similar recommendation over 2 or more years. And Kimberly, if you'll just scroll down a little more. I just want to see if there's, yeah, it's all that same kind of format. Yeah, so this was a 2023 recommendation. So creating a bill draft request at the legislature, again, that's something that you'd want to direct to a legislator, or you could, committees also have a certain number of bills that they can move forward, but you have to actually go and testify to them. So, any questions about that?
Thanks, Lauren. I think Jessica may have some additional
Yeah.
requests around this document that is so great and detailed, and I hope very useful.
Yes, I can definitely see that. Fellow subcommittee members, first, huge thank you to SEI and specifically Laura for pulling all of these details together and really trying to answer as my request. So really grateful for you trying to answer my question, which was, have we seen progress on the recommendations that we made in the 2024 SURG report? And if so, what does that look like? So my request to the subcommittee, and happy to take any questions from Angela or Eric if you have them, really is when this document becomes available to subcommittee members, I want you to look through it for kind of four things, like related to recommendations. Like, I want to know your questions. So if you have questions about any of these updates, we can add them in and just say, hey, we're wondering, like, for this first example related to funding, was this additional funding that was allocated, or was this from the same pot of money that went to prevention? So can we count it as like a win for the increase column, or was there a cut somewhere else and this was meant to offset it? So I think that would be helpful to know if you have questions like that. I want to know if we should keep these recommendations. So if based on your review of this document, your recommendation is to keep the ones from last year as worded, we'll need to resubmit them on the spreadsheet that Kim sent out. If we want to modify the recommendation based on this information, even if you're not sure how to do that yet, we can put that into the survey to get that process going. So it's on our radar. We want a modification of a recommendation and we need to hear from such and such group about how to do that, or I need to bring it up for discussion in the committee. And then, or if we need to delete a recommendation or omit it altogether, I think it would be helpful to know, but obviously you're not submitting that, tells us that we should take it off our radar. So that's my ask. I think once this becomes available, if we can do that in advance of our June meeting, that would be really helpful so that we can make sure that we are adding things to our agenda and hearing presentations about things that are relevant to moving forward. Does that make sense? Does anybody have any questions at this juncture? And again, a huge thank you to Laura for all the research and behind the scenes and communication, and all the staff that put in and submitted information.
Yeah, no questions from me, Chair Johnson.
Okay, thank you so much. Wonderful. With that, we're going to move to agenda item 6. We're going to just discuss briefly the proposed 2025 Prevention Subcommittee recommendations. On the next slide, again, just a reminder of the process. Subcommittee members will submit recommendations via the link that Kim has shared with us. The earlier they're submitted, the more time we have to hear presentations about them. So I think, to my point in agenda item 5, please review and submit ideas as soon as we can so we can bring on excellent presenters like we had today from Dr. Morgan and Josh to talk specifically about recommendations. And I would love for everyone to at least submit one recommendation. If you're unsure of what to do, you could submit one from last year after you review Laura's document to keep it back on the list. That might be some low-hanging fruit, but I'd love to see one from at least everybody on the committee this particular year. Any additional, and we're going to talk about the ones that These are the ones that are existing, Kim, is that correct?
So I'll just note that there are 2 slides here. The first one, they are both recommendations that were submitted for 2025 via the current survey. One of our subcommittee members is re-elevating, similar to what you just
Thank
said,
you.
Jessica, is re-elevating one of the recommendations included in the 2024 annual report, which is related to that bill draft request of allocating a set aside from cannabis retail funds.
Okay.
So
Thank you very much. And I know SEI staff has been working hard on a presentation. This is Ms. Nadler's elevation of this particular recommendation. Working hard on with a presenter that she recommended. Their schedule is has been international, so we've been a little challenged to have it match up, but are continuing that work. So right now, this is one proposed recommendation that we have, and then as I alluded to earlier, this is a new recommendation about requesting some guidance. I liked some of what our presenter put together to help this recommendation be more specific. So I intend to review the previous presentation and amend some of this language, but my drafted language was around guidance from Board of Pharmacy on this distribution of naloxone for non-pharmacy storage, so we can distribute naloxone to the community. And this was requested by a community member, something they identified. So really grateful to have the opportunity to elevate this. Any questions or additional points of discussion at this time? I will add that we are confirming speakers for June with the Boys and Girls Club, who will be able to come in and talk about some of the statewide programming around prevention that they've been working on based on the Fund for Resilient Nevada um, uh, uh, report is the word I'm looking for that came out. Any additional questions before we move on to our presentation at agenda item number 7? All right, seeing none, we will move to agenda item 7, which is an update on the multi-tiered system of support, the MTSS project. We have some excellent presenters here with us today, and in the interest of not butchering names or titles, are you okay introducing yourselves, hopefully? And I'm really grateful to have your engagement and leadership here today.
Absolutely. Thank you for that. My name is Casey Fleetwood. I am joined by my colleague and director, Dr. Ashley Greenwald, and also on the phone is one of our teammates, Brooke Wagner, who is en route to Las Vegas as we speak. But we are honored to be requested to come present to you guys today about multi-tiered systems of support, or what we will say for short, MTSS in Nevada. I know that I've got 15 minutes and then some times for questions, so I'm just gonna, beat feet a little bit and move forward. And I really invite and encourage any questions you have at the end of this short little update here. So we are a statewide project that is funded by a variety of funding streams, and we have staff all over the state, but our administrative house is in the University of Nevada, Reno. And we primarily in this work with school districts, with local education agencies, their collaborating partners, and with the State Department of Education to build prevention, intervention, and treatment frameworks in schools for both clinical and non-clinical supports. What you're seeing on this slide is what we call lovingly is the tattoo of MTSS. So when people are like, what do these letters mean? Normally what we'll do is when I start a partnership with the district, we identify what are your valued outcomes as a community, as a district, as a school. And then we'll look into community and school-based data to see what's your level of need around those specific outcomes. We will help the district select evidence-based practices to meet those needs. We'll provide training, coaching, and technical assistance on whatever those practices are. And most of our work, being systems in the name, is supporting the systems to actually get those things from, cool, people went to training to actually being implemented in practice. For those of you who follow implementation science, without good system supports, it takes over 17 years to get maybe 20% of EBPs in place, evidence-based practices in place. And we know that with, intentionality and focus, we can get 80% of EBPs that are selected within a system within 3 years, using some of the supports that we'll share a little bit about today. Our work is based in public health. So many of you are probably familiar with a 3-tiered continuum of support. Because we are working in schools, we are supporting the academic side of that, the social emotional side of that, and the behavioral side of that. Just for some history, our center has been operating since 1999 with very behavioral roots, so very much working in the social behavioral space, and has sort of branched out in scope in recent years. So for those of you who are familiar with, the continuum of support, that's fantastic. In addition to just having practices at the various levels of need, MTSS is really defined by core features. So we help districts in our state to install high quality prevention supports that are universally accessed, evidence-based interventions at all the levels, engaging in screening, universal screening, targeted screening, also some indicated screening, progress monitoring for students that are receiving intervention at the advanced tiers, and really kind of that database decision making. And we do that at the site level, at the district level, and at the state level. So like today, I'm in at our Redfield campus location because for the past 2 days, I've been training our clinicians in how to do tier 3 documentation and electronic health records and monitor treatment fidelity, right, for students with those intensive needs. So we kind of work from the smallest, nugget to the larger system scale there. At tier 1, universally, this means everyone receives it. So if we're doing substance prevention programming, that means that every student in the school or every student in the grade level is receiving access to that support. We often provide training in that. So for example, yesterday afternoon, one of our trainers, Dr. Humphreys, was doing a Too Good for Drugs training, right, to kind of build some more capacity around that. At tier 2, for students who rise to having additional need, that same intervention, so whatever we select with the district and the school based on their need, is provided to students that are identified with consistent data, entry criteria, and exit criteria. So in this space, we might be looking at targeted screeners, elevated risk on universal screeners, things like the CRAFT or the audit or things like that might show up. And then at tier 3, building those comprehensive support plans for kids with complex needs. Knowing the topic of your group and what you're probably more interested in, I kind of honed in on some of the substance specific evidence-based practices and screeners and assessments that we provide training and coaching to with our schools. So as you'll see at the tier 1 bubble down here, these are really universal screening assessments that we're scaling. A lot of districts, Clark has a different one than Carson City, and Carson City has a different one that, so like they all select sometimes some different screeners, but we help to guide them to valid screeners. And then once students may, kind of pop hot on a universal screener, what kind of targeted screeners might we need to layer in there to appropriately route kids to the, most appropriate intervention? And then at tier 3, we're looking at those individualized, more deeper assessments so that we can build comprehensive treatment plans, and what those interventions may look like. You can see in the bubbles on the right? So a variety of evidence-based, universal, targeted, and indicated prevention, intervention, and treatment modalities there. In terms of our structure, I have Dr. Greenwald on the call. She works across many state agencies to help strategic planning and alignment, because, you know, there's a lot of intersectionality in this work, right, across different collaborating agencies. And she spends a lot of her time working with the various directors at the Department of Education. I myself spend most of my time in school districts, meeting with our various cabinets and district community leadership teams, helping them to install, scale, and sustain and innovate their MTSS systems. And then on this call, I have Brooke Wagner, who's my coaching coordinator. I also have a training coordinator who's busy training right now. But they support sort of mid-level management in our districts and provide training to end-level providers, school administrators, folks on school teams who are moving forward this work. So that's just a little touch of our structure. We are working with a variety of our state partners. So we're working with, 76% of our local education agencies at this point in time. We are, come join us when you're able to kind of approach with them. So serving a lot of students and scaling every year. Our newest friends in the club are Story County. They just joined us within the past, 90 days. So we're excited to, always bring new friends on board, but we have districts that are well into deep implementation we've been partnering with for over a decade, and then some friends who are really novel and just starting to install their journey. Data, you either love data or you hate it, so I'll be kind. We have some really wonderful outcomes that we're proud of. Just a little sampling here today. We compare our schools that are implementing MTSS with high fidelity, which would be the green lines, to schools that are not implementing with fidelity, which would be the orange line. And longitudinally, we look at a few indicators, right? So average daily attendance statewide, just getting kids to school to connected environments, has not been looking that phenomenal post-pandemic. But we do see that our schools who are implementing MTSS with fidelity have small, higher average daily attendance. This looks a little bit better, that our higher implementing schools have lower rates of chronic absenteeism. In the academic space, higher outcomes in math, higher outcomes in English and language arts. And if the graphs are hard, there's a table in here, and this is PDF'd and accessible for you if you want to nerd out on it later. Probably what you might be more excited about, though, are, some of these specific NRS violations. So on the Nevada School Report Card, there's, what I informally call like the 7 deadly sins, right? There's a few NRS violations that have to be documented no matter where you are in the state. And those are, violence, weapons, and then a lot of the substance indicators, right? So use of alcoholic beverages, possession, use of controlled substances, and possession of controlled substance. And honestly, when we look at our outcomes, these are where our strongest outcomes are in terms of student outcomes for MTSS work. You can see the disparities between the lower implementing schools and the higher implementing schools is much more discrepant than some of those like small gains in the attendance and academic space. So really proud to see that our schools implementing with fidelity are doing so much better than schools that are not implementing MTSS with fidelity. Similarly, for some of those like social items around bullying, cyberbullying, harassment, discrimination, we see similar outcomes. So a lot of those social components, right? And just lumped risky behavior, right? Seeing really phenomenal outcomes there. So there's a table that green is good, right? So all these things are looking good. We have these data produced by an external evaluator so that we can exclude ourselves from any bias in our reporting. And these are all run from the Nevada report card data, which are publicly accessible. So no secret ends there. For schools that are implementing MTSS, a component that we have core to that is school-wide positive behavior support. There's a lot of published research on the efficacy of school-wide positive behavior support, demonstrating lower uses of substance and alcohol, particularly in high schools, and we see that in our data locally as well. But this ROI study is really something I like to draw to folks' attention, is that for every $1 that's invested in these tiered prevention systems in schools using this MTSS framework, it results in a fiscal savings of $104.90. So, ounce of prevention worth a pound of cure thing here. And, we were not always focused explicitly on substance. Like I said, behavior at large was kind of our cup of tea. And then for the past 2 fiscal years, we were really grateful to receive some Fund for Resilient Nevada funding in FY24 and currently in FY25, but that funding, we've been informed, is coming to an end. So really grateful for that opportunity. It's obviously allowed us to scale and, produce those outcomes that I was able to share with you today. I have my email address here, but I'm instructed I have 15 minutes to talk. I'm running about 3 minutes ahead of schedule, and then 15 minutes to potentially field some questions. So I would really appreciate any comments, questions, or concerns that we can respond to. And thank you so much for this opportunity.
Yeah, thank you so much for a dynamic and engaging presentation. I was writing questions and then they were getting answers, so I was crossing them off. So I really appreciate those details here. I'll turn it over to my subcommittee, Member Nichols or Member Schoen, or Vice Chair Schoen. If you have any questions out the gate for our presenters.
I do, but Angela, did you have any questions or comments? Okay.
Sorry, I'm having difficulty with the mute button. No, I don't have any questions or comments, but I just, in the district, we do support the MTSS system. And, it's, I don't know from a personal standpoint about the dollar per ratio, but from what you have to deal with down the line kind of ratio, the prevention thing that, hey, just having conversations with kids and intervening saves big headaches from an administrative standpoint. Down the line, I need fewer gray hairs, and that helps with it.
Thank you, Angela.
Yeah. So Casey, good to see you. Question. So I know the funding, the specific funding is going away June 2025. And I heard a rumor, and you know how rumors are yesterday, that a lot of funding that's been available for mental health supports from the state level at the schools is not going to be available going forward. So I'm curious if you guys are able to share some thoughts on, what the next couple of years will look like in terms of what supports MTSS will be able to provide participating school districts.
Yeah, I might defer to my director on that one because we're reading tea leaves pretty closely at this point.
And you may not want to prognosticate, I totally get that, but any thoughts you might have?
Sure, I can't answer with certainty, so I'll defer to my chain of command.
For the record, this is Ashley Greenwald. I also cannot answer that with any certainty, unfortunately. We find ourselves in a position that we've really never found ourselves in before. Like Casey said, the center has been in existence since '99. We've had sustainable sources of funding and increased funding every year for the MTSS initiative since the inception of it in about 2012. And so this is the first year that we kind of find ourselves wondering the very same thing that you've asked, Eric, is what does the future of funding look like for MTSS and what type of supports will we at the TA Center be able to provide? You know, we are at University of Nevada, Reno, but we operate a statewide technical assistance center. So we're just, you know, like formally housed here, but we have extension offices in our rural communities, and we have employees in an extension office in Las Vegas. So, you know, we've got a really large, robust network of employees that help support the state, the districts, the schools, and at this point, you know, we've got a lot of champions for this work, which has been very helpful. We've, you know, obviously built a lot of relationships over the last decade plus. We have had really, really excellent outcomes for our high implementers, and we've been able to demonstrate that. Anecdotally, thank you to Angela, who made a comment about that. You know, people who implement MTSS over time really do feel both, you know, you see it in the data, but you also feel the effects of MTSS at the local level. So we have a lot of champions in the work, which is helpful. There are many different sort of avenues that we've been working with the state agencies on to try to secure funding going forward. But as you all know, you know, state funding is challenging to secure in a time of deficit, and federal funds are largely unavailable at this point for this type of work. So we are holding our breath and hoping for really good outcomes going forward in the fiscal space. So at this point, it's hard for me to answer that question.
Thank you for your answer. Vice Chair Schoen, any additional questions from you? I think you hit the one out of the ballpark with the first one. So
Yeah, no questions for me. I wish you guys luck because it's gonna be a bumpy ride the next few weeks, at least.
at least.
Yep.
Yeah, thank you. I just had a couple of questions. Casey, these might be ones related to your presentation, but I was wondering so you showed us the map of kind of the different counties, and I'm from Clark, so I know that the population wise, there's a lot of variability in those. I was wondering if you could talk about kind of what reach looks like within particular counties. I'm curious about like curriculum kind of selection. Does that happen at the district level, at the principal level? Does it depend? And then what does your reach kind of look like within counties and since you presented across counties?
Yeah, let me just write those things down, reach and curriculum, because once I start talking, my working memory goes out the door. In terms of reach for our rural districts, reach is great because we can scale up to 100% of schools pretty quickly, you know, if not within 2 years, by 3. So when you're thinking about like Carson City, Lyon County, Humboldt County, right? Like if they're on the map, they're all with us, right? There are 3 districts that we are not to scale in. That would be Washoe County, the State Public Charter School Authority, and Clark County. It has taken some time to build. So specific to your question with Clark County, you know, we're teetering around 135-ish schools of the 374. So I mean, we're chugging away, but we still have definitely some room to grow. There's kind of 3 things that put a school on the like active implementation list in terms of our perspective of whether they're included in the Cool Club or not, right? One is that they have an MTSS team, right? That is facilitated at their site level, and that team is accessing training. We provide the training statewide. In many districts, we, you know, build capacity so that they, you know, have some local capacity to do that without us. With turnover lately and teachers on special assignment being kind of cut, we've leaned in a little harder to fulfill that role for our districts. The other one is that they are collecting fidelity data. So beyond just saying like, oh yeah, we do that, we actually 3 times a year have data points from each of those sites, right? So those 200 plus schools in the state, we have data that says, yeah, we implement this and we're progress monitoring at a state and a district level how they're doing with their scaling of their tiered interventions and supports. And then the third thing, and this is the probably the trickiest widget, is they're receiving some coaching support, right? So beyond training, beyond having a team, having access to somebody who can come to their building and help them like contextualize those programs and whatever they're working on, because every school is kind of in a different place and may have a different focus, yada, yada, yada. In terms of curricula, so there's two things. Number one is oftentimes, and I'll pick on new districts, when we say, hey, what are we doing district wide? Every year we do an annual initiative inventory. What programming and curriculum are you doing at tier 1? What are you doing at tier 2? What are you doing at tier 3? For our new friends, sometimes we don't even know what's going on in our schools. It's kind of like local control, Wild West. We don't endorse anything. It's everybody choose their own adventure. MTSS is really about, refining at the district level. What curriculum and programming are we going to support at the district level, right? So like kind of a base level of care. What is the standard social emotional learning program? What is the standard substance prevention program, right? What is the standard, whatever that is at tier 1? And then for tier 2, what evidence-based interventions can we layer in? So we encourage districts to select, and we have some tools out of the National Implementation Research Network that we lean into, and we facilitate a lot of, structured conversations around how do you select a program, right, that's going to meet your needs, has good evidence, can demonstrate effects in populations like yours. And we help the district to select, scale, install, coach, train those programs across the tiers, right? But what the district selects and supports is like a base standard of care. There are schools that, supplement and maybe doing things in addition to that maybe isn't district supported, right? The caveat to that is like our state public charter school authority, they probably have the most variability just because they don't, by nature adhere to being told what to do. That's why they're charters. So that's sort of the curriculum standpoint. But we do want to say, like, as a district, right, what can we provide to students that's evidence-based, treatment at tier 3, intervention at tier 2, prevention at tier 1? How can we scale those things so that every school has access in an equitable way and can get those resources regardless of their means and resources, because there's a lot of disparities between what schools can access as well. Does that answer your question, Jessica?
Yeah, it does. Thank
Okay.
you very much. My daughter started a Leader in Me program this year that has been really successful. That's probably one of your tier 1s, I imagine. So
A lot of communities will engage in some Leader in Me at tier 1, yeah, as a
yeah,
social emotional learning program.
yeah, thank you.
Mhm.
Any additional questions for the committee for this particular group? I think my only sort of parting thought, and if this is something that you can answer now or you want to follow up with on email, I think if you're if MTSS, I think based on our recommendations around SURG from the prevention side of the house, sees any opportunity to enhance or expand sort any of the components that we have as recommendations, would be really interested to see where that alignment might look like for our committee to consider kind of how we continue to expand prevention programming across the state that's evidence-based and effective for our students.
Yeah, I'll make a quick response that we would be honored and interested in doing that too in a thoughtful and collaborative way. So if you have priorities that you think we could support, be happy to have a robust conversation about how to best partner on that if appropriate.
Thank you.
Yeah.
All right, wonderful. Well, thank you so much for an excellent presentation. I'm going to move on to agenda item number 8. We're going to just discuss a brief report out for our July 9th meeting. Don't skip over June, though. We'll be meeting again in June, but just by way of a report for July 9th, historically, as chair, I've been serving for a report out for July 9th. I'll be traveling, all else being equal, on July 9th for a grant site visit meeting in Atlanta. So Vice Chair Schoen, I'm hoping that perhaps you might be available in case my internet connection goes sideways.
I think I am available, yes.
Okay, wonderful. I'll be connecting from an Atlanta
Mhm.
Marriott, so hopefully,
Mhm.
hopefully that connection is robust enough. All right. And unless the committee objects, I'm happy to prepare some brief statements on the presentations received today and the subsequent discussions.
No objections here.
All right, hearing none, we'll move to our second period of a public comment. Kim, I will turn it over to you just to make sure we're in compliance if there's anything additional that we need to make note of for the second period of public comment.
So public comment will be received via this Zoom meeting. Folks may unmute themselves or raise their hand. When asked for public comment, you are limited to 3 minutes per person. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken. If you are dialing in from a telephone, you will dial 253-205-0468. When prompted, you will enter the meeting ID of 825-0031-7472, and we would ask you to press *6 so that the host can prompt you to unmute. And I will turn it back to you, Jessica.
Okay, fantastic. Do we have anyone for the second period of public comment? I used to teach middle school after school programs. I can wait a long time, so happy to hold a silence just to give folks time to find the raise hand button or their unmute button. All right, I don't see anyone for the second period of public comment. So we can go ahead and close that. And we'll move to agenda item number 10, which is adjournment. Thank you, committee members and SEI staff, AG staff, and others, community members who've joined us today for the Prevention Subcommittee. Looking forward to the next one.
Okay, take care, everybody.
Thank you.